Hi everyone, and continuing with the previous video, I share and teach regarding unstable angina and myocardial infarction in this section. This is also comes under coronary artery disease. First, we see the overall classification of coronary artery disease. As we discussed in the earlier video, coronary artery disease is consists of chronic stable angina as well as acute coronary syndrome. Acute coronary syndrome is further categorized into unstable angina and acute myocardial infarction. That is on the basis of the clinical presentation of the condition. Then acute myocardial infarction is further to non-ST segmental elevated MI. Usually we denote this with NST-MI, NSTE-MI, and ST segmental elevation MI, that is STE-MI. Okay, this is the overall view of for the overall picturization of coronary artery disease. Then we are already in the previous video it is detailed discussed about the chronic stable angina. So in this video detail see about unstable angina and acute myocardial infarction. First of all, unstable angina. Unstable angina, that is a chest pain that is new in onset, occurs at rest, or has a worsening pattern. In the types of angina, we discussed that unstable angina, it is unpredictable. Even at rest also, patient develops pain, and the pain intensity and the duration is more, and also it will not relieve by medication. That is, occur with increasing frequency and is easily provoked by minimal or no exertion during sleep or even at rest. Then management of unstable angina. The goal of medical management is increase oxygen supply and decrease oxygen demand. Already know the angina or the chest pain develops when there is a decreased oxygen supply than demand. What happens there? There is a instead of aerobic glycolysis, there develops anaerobic glycolysis. So patients develop with the chest pain. So main goal of management is increase oxygen supply and decrease oxygen demand to the myocardium. Then prevent myocardial infarction and death and to actively intervene the condition. This is the goal of medical management. Then next is the management. We supposed to take totally ECG. ECG that shows the significant chest pain without ECG changes or with changes treated as a myocardial infarction. We can predict whether it is a ST elevation is there or no ST elevation, whether that Q wave presence is there or not. Then laboratory tests like electrolytes and cardiac enzymes, the cardiac biomarkers, we can identify and rule out it as it is MI and treat according to that. This is what the goals of management. Then management for unstable angina, it is the first relief of chest pain. We use the synonym ONAM, that is ONAM. It represents O represents oxygen, N nitroglycerin, A aspirin, and M morphine. So, what is its relevance? That is already said there is a because of decreased oxygen supply, there is a anaerobic glycolysis. Because of there is lactic acid secretion, and that is the reason for the chest pain or the reason for the myocardial cell death and for the worsening of condition. So to relieve that, we supposed to administer oxygen. Then nitroglycerin. Nitroglycerin has the action of vasodilation. The previous video it is discussed. When there is a vasodilation, it will improve the blood perfusion as well as it will reduce the systemic vascular resistance, thereby reverse the anaerobic to aerobic glycolysis. Similarly, aspirin and morphine also have the effects of vasodilation and improve the perfusion or the blood circulation will be promoted. Then increase coronary artery blood flow. To increase the coronary artery blood flow, we are supposed to administer antiplatelet medication, that is ASA, acetyl salicylic acid, that is used in aspirin derivatives. Then glycoprotein and heparin. Then percutaneous coronary intervention. This is for the management for unstable angina. Regarding percutaneous coronary intervention, we detail discuss later after myocardial infarction. So in this picture, when you see it is an overall picturization, we can give an overall view of management. That is, our goal of management is decrease the oxygen demand. This is our goal of management: decrease oxygen demand and increase the blood oxygen supply. So to decrease the oxygen demand, we are supposed to decrease the contractility of heart or myocardium, decrease heart rate. Then for that, we administer beta blockers, calcium and calcium channel blockers. Beta blockers drug of choice are propranolol, metoprolol. Calcium channel blockers, verapamil and all comes. Then decrease afterload. Regarding afterload, we supposed to know means in the previous section, previous videos you can visualize, detailedly discussed about what is afterload, what is preload and all. Then to decrease the afterload, administer angiotensin converting enzyme inhibitor. Then next is that to decrease the oxygen demand, management should be to decrease the preload. To decrease preload, we are supposed to administer nitroglycerin, angiotensin converting enzyme inhibitor and morphine sulfate. On the other hand, increase the supply, increase the oxygen supply, that is by increase blood flow as well as open the occluded artery. To increase the blood flow, administer nitroglycerin, calcium channel blocker, acetylsalicylic acid, anticoagulants and morphine sulfate. Then to open the occluded arteries, the management option is percutaneous coronary intervention. Then nursing interventions in case of unstable angina. So nursing interventions include, first of all, early identification of chest pain. The nurses should be aware or vigilant about the chest pain, and they're supposed to know about the early identification or rule out the chest pain, whether exactly it is related to angina or not. Then assessment of chest pain. Chest pain is assessed by the intensity scales. Then and characteristic by the old card, that is we supposed to analyze by the certain instruments we can use for analyzing the chest pain. Then mention the overall tissue perfusion, then vital signs, heart rhythm, pulse oximetry, then diagnostic like totally DCG, and laboratory test like cardiac markers, and also management of chest pain, that is a mono, otherwise onum. There is a this video I have said about onum, oxygen, nitroglycerin, aspirin and morphine. In both ways it is right. Okay. So this is the nurse's role. Then provide calm environment. There is anxiety and fear of impending doom or death is there, because they always have the fear of the life, threaten to life. So provide calm environment. Activity restrictions. Activity restrictions means reducing activity. We reduce the metabolic demand in the body, thereby reducing the oxygen demand. So it will support for the reducing pain. Then similarly avoid valsalva maneuver, in the sense it may lead to any arrhythmia chances. Then educate the patient for what are the risk factors of coronary artery disease, which are the signs and symptoms of angina, and how could differentiate the significantly they can identify the features of angina. Then teach about the medications, its actions and the users. Then when to call the doctor, and when they find any warning signs of any abnormality they can call the doctor. Then stress management techniques. These are the main nursing interventions for patients with the unstable angina. Okay. Here we discuss about myocardial infarction. Myocardial infarction which result from sustained ischemia causing irreversible myocardial cell death, or cell death otherwise we say is a term of necrosis. So what is the definition of myocardial infarction? Myocardial infarction is an irreversible necrosis or death of myocardial tissue resulting from abrupt decrease or total lack of coronary blood supply. So it is self-explainable, as it is, as we already learn about atherosclerosis and angina and all. So when there is a coronary occlusion or decrease of perfusion to the myocardium, there is a death of the myocardial tissue. That is in the state of irreversible. That is a term we say, there is a situation we say the condition of the myocardial infarction. So the main causes are coronary artery thrombosis, then coronary artery vasospasm, cocaine, trauma, or severe and abrupt hypotension. These are the situations that leads to abrupt or lack of coronary supply, as well as that leads to myocardial infarction. Then risk factors are as discussed in the previous section. That is same modifiable and non-modifiable factors. So the risk factors for the development of MI. We see the pathophysiology of myocardial infarction. As you know, already said the etiological factors like atherosclerosis, coronary thrombosis or embolism that leads to narrowing of coronary artery. When there is a narrowing of coronary artery, there is a decreased myocardial oxygen supply. When there is a decreased myocardial oxygen supply, that is the increased cellular hypoxia and decreased cardiac output. Okay, so decreased arterial pressure and that leads to further myocardial ischemia. Then stimulation of baroreceptors that leads to stimulation of sympathetic receptors. Thereby there is an increased myocardial contractility, increased heart rate and decrease the myocardial tissue perfusion. On the other hand, because of the stimulation of sympathetic receptors, there is increased peripheral vasoconstriction and increased afterload, and there is also further decreased myocardial tissue perfusion and myocardial cell death. This is a pathophysiology or the physiological changes develop at the how MI progress. Okay. Then further it lead to the clinical features. The clinical manifestations like first of all chest pain. The chest pain, the characters of chest pain is it is a severe unrelenting substernal chest pain, often radiating to back, left arm or jaw, lasting for 30 minutes or more, only relieved by opioids like morphine sulfate is the drug of choice to relieve the chest pain. It occurs without a non-precipitating event, usually occurring in the morning. The associated symptoms are shortness of breath, weakness, anxiety, diaphoresis, nausea and vomiting, dizziness or numbness in the upper extremities. Other than these features, there is a sympathetic nerve system stimulation. Then other cardiovascular manifestations like tachycardia, hypotension, palpitation, certain times arrhythmia, and also patient present with the fever. This is a pictorial representation which are the areas patients sense pain during MI or angina. So the locations of chest pain during angina or MI is upper chest, substernal radiating to neck and jaw, substernal radiating to down left arm, and epigastric pain, epigastric radiating to neck, jaw and arms, and certain times only neck and jaw, then left shoulder and down both arms, and intrascapular. This is for the pictorial or the locations where patient sense pain during myocardial infarction. Then the diagnostic measures. What are the common diagnostic tests we can perform to rule out MI? First and foremost is the as it is for everything, that is a history and physical examination. Then the basic assessment is electrocardiogram. That is, in the ECG we can find if it is a myocardial ischemia, there will be a T wave inversion. If it is a myocardial injury, then ST segmental elevation present in the ECG, and myocardial infarction, there is a pathological Q wave present in the total ECG. Then next is the serum cardiac markers. Serum cardiac markers detailedly I explained in the previous video, the diagnostic measures and all. Here also we see the creatinine kinase, because creatinine kinase it will rise in 3 to 12 hours after MI. So cardiac specific troponin. Then there is cardiac specific troponin T and troponin I used to check. Regarding troponin, it increase 3 to 12 hours after the onset and peak at 24 to 28 hours, and it lasts for 14 days. Then there is the most reliable one. Then myoglobin. Myoglobin releases into circulation within a few hours after MI, and also it rapidly excreted in urine. So this is the basic markers. Detail about cardiac markers, you just see the other video that is detailedly explained about each of the parameters. Then types of myocardial infarction. So on the basis of muscle layer affected, it is termed into Q wave myocardial infarction and non-Q wave myocardial infarction. The Q wave myocardial infarction is a transmural, that is full thickness muscle wall necrosis, often associated with a more prolonged MI. Whereas the non-Q wave MI, there is a partial thickness muscle wall necrosis, often associated with a smaller, less complete occlusions. That is subendocardial necrosis of the inner one-third or half of the muscle wall. This is according to the muscle layer affected. It is Q-wave MI as well as non-Q-wave MI. Then, according to the anatomical location, it is classified into it is a left ventricle and right ventricle. When comes the left ventricle, anterior wall myocardial infarction. Anterior wall myocardial infarction. So, when there is an anterior wall myocardial infarction, the affected artery or the occluded artery will be left anterior descending or LAD. That is a left anterior descending coronary artery associated with the left ventricular failure, pulmonary edema, and cardiogenic shock. Then, if it is the inferior wall myocardial infarction, the affected coronary artery will be right coronary artery associated with the dysrhythmia and conduction disturbances. Then, posterior wall myocardial infarction, there will be right coronary or circumflex artery will be the affected coronary artery. Then, next, if it is the left ventricle, the portion of right coronary artery is the affected coronary artery, that is occluded artery in right ventricle. Then what are the complications? There is post-acute MI. So when the patient admitted with acute MI, we are supposed to predict certain complications may arise immediately. First and foremost is the dysrhythmia. As you know, dysrhythmia is abnormal electrical impulses or abnormal electrical activity in the heart. Different types where we are discussed. Then like atrial arrhythmia, sinus arrhythmia, ventricular arrhythmia, and junctional arrhythmias, especially ventricular tachycardia, ventricular fibula, so on. Dysarrhythmia also are discussed in other videos. Then next is the ventricular aneurysm. Ventricular aneurysm, as you know, there is an abnormal dilation of the arteries. So ventricular aneurysm that leads to acute heart failure, emboli, and ventricular tachycardia. The next is the ventricular septal defect. Ventricular septal defect most often seen rupture of septum. That is a shunt. Then there is a shunting of blood. There is a intraventricular septum will be ruptured. So directly connection with the right and left ventricles. That is the shunting of blood. Then the signs and symptoms like severe chest pain, syncope, decreased blood pressure, and hollow systolic murmur. Then the medical emergency is a high mortality rate, surgery to correct. Immediate surgery is supposed to be performed. Otherwise, there is a high mortality in case there is a septal rupture. Then another complication is pericarditis. Pericarditis in the sense an inflammation of the pericardial sac. The signs and symptoms is pain, friction rub, that is left sternal border. The treatment is non-steroid anti-inflammatory drugs and ASA, that is acetylsalicylic acid, that is aspirins. So see the management for acute myocardial infarction. Here also the goal of medical management is control chest pain, preserve the myocardium, because once it is a fully affected means it is irreversible. So try to preserve the myocardium. Then prevention or management of complications and pharmacological or intervention based therapies. Next is electrocardiogram. Positive changes or severe chest pain despite medical therapies. Then laboratory tests like is supposed to check for electrolytes level and cardiac enzymes. Then rule in MI and then monitor the response to treatment. Okay, this is a pictorial representation of the emergency management for patients with acute myocardial infarction. So when the patient senses the onset of symptoms like a chest pain and also the chest pain is radiating, and what are the characters we already discussed, so immediately they are supposed to activate the emergency medical service. That is EMS represents emergency medical service. So here it is given 911, that is the that is in the European country, I think. So whichever the locality, we are supposed to learn about the emergency number of the particular locality and activate the emergency medical service. Then once the emergency medical service reached over there, we encourage 12 lead ECG. Immediately take the 12 lead ECG and rule out the characters of MI, and we recognize what is exactly which type of MI is that. Then immediately consider pre-hospital fibrinolytic therapy if possible, and the emergency medical system to needle within 30 minutes, that is door to needle within 30 minutes. Door to needle in the sense fibrinolytic therapy. If it is possible, perform fibrinolytic therapy, that is in the within 30 minutes. If it is say those means there is a reperfusion will be successful. Then this is what the triage, that is EMS triage plan, that is emergency medical system. Then if it is capable to do percutaneous coronary intervention, then not capable of doing percutaneous coronary intervention, then transfer the patient to the hospital. That is, if it is not PC is capable, hospital fibrinolysis, that is door to needle within 30 minutes, then inter-hospital transfer for the percutaneous coronary intervention if it is capable. Then goals of the management in the sense 5 minutes, that's a patient factor. Dispatch time supposed to be 1 minute and 8 minutes supposed to be emergency medical service. Then EMS transport, that is pre-hospital fibrinolysis, that is door to needle, that is EMS to needle within 30 minutes. Then once transported the patient, EMS to balloon within 90 minutes, and a patient self-transport means hospital door to balloon within 90 minutes. This is a golden hour. It is a golden hour for emergency management is first 60 minutes. Okay, so total ischemic time is within 120 minutes. That is emergency management, that is 30 minutes, and if it is in the hospital within 90 minutes, they are supposed to perform door to balloon, that is percutaneous coronary intervention. Door to needle in the sense fibrinolytic therapy. Okay, golden hour is first 60 minutes, that is the first 1 hour is said as golden hour. Total ischemic time is 120 minutes. Next is the management of an acute MI. This is the overall schematic show. So here also the goal of management is decrease demand and increase oxygen supply. Then to decrease the oxygen demand, that is the definitely as discussed earlier, decrease the contractility and decrease heart rate and decrease afterload. The drug of choices are beta blockers, calcium channel blockers, and to decrease the afterload, angiotensin converting enzyme inhibitor. Then to decrease the preload, nitroglycerin, angiotensin converting enzyme inhibitor, and morphine sulfate. Similarly, to decrease oxygen supply, we are supposed to perform increase blood flow as well as open occluded arteries. To increase the blood flow, administer nitroglycerin, administer calcium channel blockers, acetylsalicylic acid, anticoagulants, and morphine sulfate. To increase the open the occluded artery, perform percutaneous coronary intervention or thrombolytic therapy or CABG, coronary artery bypass graft. Then what is thrombolytic therapy? Thrombolytic therapy, it preserves the ischemic myocardium and limit the size of infarction by restoring blood flow quickly. So this is something emergency procedure, as we said earlier, within 30 minutes as early as possible, we are supposed to perform fibrinolytic therapy or the thrombolytic therapy. The thrombolytic agents which work by causing the lysis of clot. It lyses the clot. That is, otherwise we say clot busters. So the drug of choice is alteplase or reteplase. Then otherwise we in the cardiac we used to say thrombolytic therapies are streptokinase. Sorry. Streptokinase or urokinase. Then eligibility for the performing thrombolytic therapy is chest pain more than 30 minutes. Then less than 12 hours from the onset of chest pain. There is many institutions. If the patient arrives within 6 hours in the onset of chest pain, we can perform thrombolytic therapy. Then positive ECG changes, that is ST elevation, presence of QA. There is a definite, we interpret that as a patient is MI. Then chest pain unrelieved with the medical therapies, that is nitroglycerin, oxygen, even morphine, it will not relieve chest pain. Then definitely we can go for these are the criteria for the eligibility to perform fibrinolytic therapy, otherwise thrombolytic therapy. Then continuing with the thrombolytic therapy, the exclusion criteria, thus contraindications for the thrombolytic therapy are history of severe cerebrovascular accident or any bleeding disorders and active internal bleeding or recent surgery. In such cases, we cannot perform thrombolytic therapies because it will further increase the risk of bleeding as well as leads to shock. Then the complications like bleeding and reperfusion dysarrhythmias. The role of nurse is the nurse is supposed to perform intravenous access, then baseline laboratory examination supposed to be completed, then monitor for subsequent laboratory tests vital signs, and for complications like bleeding, then sudden drop of blood pressure, and also we're supposed to take bleeding precautions. The next is the percutaneous coronary intervention. Percutaneous coronary intervention, as it is says, it is something umbrella term. Why? Because all various interventional cardiac catheterization procedures are comes under the percutaneous coronary intervention. So the indications like angina refractory to medical therapy and proximal coronary artery stenosis, or like single or double vessel diseases. So that we can identify by the coronary angiogram. Then certain procedures and nursing care like much the same as cardiac catheterization, except venous and arterial catheters. Large lumen, like as it is says, for cardiac catheterization means if it is a right cardiac catheterization, we use a venous approach, and for the left cardiac catheterization, we use arterial approach. But here, as percutaneous coronary intervention, right or left side, we prefer to access. The choice of route of access is arterial, because through the arterial approach, maybe femoral artery, maybe radial artery, we reach the root of aorta. Then from the root of aorta only we can enter into the coronary arteries. That is why it says same. So the procedure is almost same as cardiac catheterization. Only exception is the it is not there is no venous or arterial catheters. That is only the arterial catheters. That is similarly the large lumen with the intervention catheterization. We use the stent or otherwise balloons for the intervention. Then different procedures are first one angioplasty. Angioplasty itself, percutaneous transluminal coronary angioplasty, otherwise we say PTCA. And another is balloon tipped catheter or expanded to dilate the vessel, otherwise we say balloon angioplasty. There we are not placing stent. Instead, we dilate with a balloon tipped catheter, then we just hold it for a while, then deflate and remove the balloon. Then, then laser UV pulse laser to vaporize the lesions. Then another procedure is atherectomy, that is removal of plaque from the vessels. Then coronary artery stenting, there is a tiny metal mesh tubes. That is usually we use the drug-eluting stent coated with the rapamune. Then brachytherapy, that is for instant restenosis. Gamma radiation therapy is used for the brachytherapy. These are the different PCI interventions or the procedures. Here in the picturization, you can see that the placement of stent, the balloon tipped catheter, the over the balloon there is a stent that is inserted and it is placed exactly in the way the blockage is there. Then over there they start to inflate the balloon. So along with the balloon, the stent also inflate and it will be placed over there. Once the stent is on the right position and the plaque is compressed on the walls, they deflate the balloon and remove the balloon. Then what is the nursing care for percutaneous coronary intervention? Before procedure, there is pre-procedure nursing care, that is explain the procedure. NPO, that is nil per oral prior to procedure, that is 8 to 12 hours before procedure, patient supposed to be in a nil per oral. Check for allergies like dye, shellfish or iodine, and laboratory examinations and results supposed to be completed. Then during the procedure, the nurse supposed to perform intravenous access, then hemodynamic monitoring. So in between procedure, there is a risk of developing arrhythmias or change in the any kind of complications may arise. So continuously monitor the hemodynamic stability. Then arterial and venous access via catheter, that is sheath. Femoral is the most common, or certain as brachial or radial. They are supposed to observe for the signs of any hemorrhage, signs of any hematoma and all. The post procedure, so this is mandatory for all patients. Maintain patient bed rest for 6 to 8 hours. So patients supposed to be confined to bed for 6 to 8 hours post procedure. The extremity should be kept straight and head of bed up to 30 degrees. Supposed to be not more than 30 degrees, supposed to be less than 30 degree only. Then maintain adequate hydration. For that, may give IV fluids if ordered. That is intravenous fluid administration always administer with caution. The reason is Certain kinds, the patient is anterior wall MI. If you are administering over fluid, means that it will end up with the pulmonary edema. So IV fluids will only if ordered, as well as identify the patient condition. If indicated, administer IV fluids. Otherwise, encourage oral fluid intake. Then frequent monitoring for complications. So for that, we supposed to analyze vital signs, puncture site for the hematoma or hemorrhage, and distal pulses to verify whether any damage to artery or anything, and laboratory results supposed to be collected like a renal function test and other values. We see the complications of percutaneous coronary intervention. First of all, acute coronary artery occlusion. That is because of any thrombosis or emboli or persistent vasospasm. Next is impaired circulation to distal extremity. That is because of the distal arterial emboli or blue toe syndrome. Blue toe syndrome, there is a disrupted plaque, occluded small vessels. Then pulses and circulation checks are good but severe. Patient develops with the severe pain. Then hemorrhagic event. So hemorrhagic event happens because of arterial tear. There is a retroperitoneal bleeding is the major complication we can expect. Then puncture site complication like bleeding or hematoma formation and also reperfusion dysarrhythmias. Then next management choice is a CABG, that is coronary artery bypass graft. Then there is a surgical management. That means a surgical revascularization procedure. Blockages are bypassed using internal mammary artery or otherwise great saphenous vein, or even use the radial artery and all. The indications are angina unrelieved by medical therapies, left main disease. Left main disease in the sense the blockage of left main coronary artery. If there is a blockage in the left main coronary artery, further there is no blood supply to the LAD or LCX. Completely there is a deprivation. So immediately the patient is supposed to go to CABG. Then triple vessel disease. Triple vessel disease in the sense TVD we usually denote. Triple vessel disease in the sense there is a blockage of three vessels. Okay. Then single or double vessel disease not amendable to PCA or failed PCA. So certain times is single vessel disease or double vessel disease, that is single block or double block, we can perform or reperfuse by percutaneous coronary intervention. Certain situations the blockage is more calcified or PCA is not performed, could not perform on particular block, means we go with the CABG. Then different surgical approaches of CABG includes on pump, otherwise traditional CABG, that is cardiopulmonary bypass machine. That is a extra corporal circulation. We use in this procedure the heart stop during the procedure. That is from the atria as well as from the aorta. One tube will be connected, one end will be connected to the atria, the blood will be collected from there and it will be externally circulated and purified, and further next end will be attached to the aorta. So the systemic circulation will be functioning and the heart is stopped for the procedure during the time. Then off-pump procedure means the beating heart procedure. That is, then we are not connecting the cardiopulmonary machine. Otherwise, heart lung machine is not connecting during the procedure. The heart is beating throughout the procedure. So we use octopus device to stabilize the myocardium during the procedure. Next is a minimally invasive direct CABG, or as we say mid-cap. Mid-cap in the sense single vessel for disease not amendable by PCA procedures is the indication for the minimal invasive procedure. Here what they do, they use a small thoracotomy incision and this is the off-pump approach CABG. Then this is a graft. Various graft we use for this. Saphenous vein we use. Saphenous vein, that is from the leg. Then internal mammary artery, radial artery, and this is a conduits used for bypass. That is what saphenous vein. Saphenous vein used for bypassing, especially right coronary artery or circumflex coronary artery. Then internal mammary artery is used for bypassing left anterior descending coronary artery. So when considered the patency rate over 90% and this lasts for more than 10 years. Then if more veins are needed, alternate sites such as upper extremity veins can be used. Patency rate is low 47% and life is for 4.6, that is around 5 years. The complications of cardiac surgery are patient may develop stroke around 2% of post-bypass reperfusion, then hypertension, bleeding, dysarrhythmia, and a cardiac tamponade. Postoperative nursing care includes that is maintain airway, patency of airway supposed to be maintained, then continuous bedside monitoring, monitor for the vital signs, monitor for the hemodynamic parameters, and monitor for any bleeding, any kind of complications. Then mediastinal chest tube management, that is chest tube supposed to be, that is monitor the drainage, the amount of drain, and avoid kinking in the tubing. Then assess pain levels frequently and provide pain relief, that is provide relief from anxiety and fear. Then assess the surgical incisions for surgical site infection. Surgical site infection is the most common complication seen. So maintain aseptic technique as well as the observe for the any complications. Assess the extremity from which the vessel harvested. Look for signs in impaired circulation and edema. Monitor for complications. This is a postoperative nursing care. Then cardiac rehabilitation for the patients undergone MI. Then education and support for client and family initiated once client is free of symptoms. That's it. It is once the patient is stabilized, we can start with educate the patient and what the patient is supposed to, what the patient not do. Then it is focuses on education, psychological support, and physical conditioning. The goals are maximize the quality of life, limit progression of coronary disease, and prevent further cardiac events. The cardiac rehabilitation phases are mainly three phases. The phase 1 is inpatient, that is immediately after the event, that is post-event we say. Education on medications, rest, activity balance, follow-up appointments, and when to call doctor or the emergency number, that is according to the nationality. That low-level physical conditioning, that is self-care and mobilization. Then phase 2, there is an outpatient supervised, that is physical conditioning, education on risk factors, modifications. Then phase 3, there is outpatient self-directed. The activities are maintain cardiovascular stability and long-term physical conditioning. This is a brief picturization of the cardiac rehabilitation. In detail, we can see that is a detailed information we get the book. This is a briefing of that. There is three phases of the inpatient, immediate outpatient, and outpatient self-directed. Then what are the nursing diagnoses? Most common diagnosis of CAD, angina or MI. So first and foremost, acute pain related to imbalance between myocardial oxygen supply and demand. Then anxiety related to fear of unknown or fear of death. Ineffectual coping related to effects of acute illness and major lifestyle changes. Activity intolerance related to fatigue, secondary to imbalance between oxygen supply and demand. The knowledge deficit related to coronary disease, angina or MI and its treatments. Similarly, patient feel powerlessness related to lack of control over current situation or disease progress. Then ineffective tissue perfusion related to impaired arterial blood flow. Then decreased cardiac output related to altered in preload, afterload, contractile or heart rate or rhythm. This is a completion of coronary artery disease. This section specially detailed about the angina pectoris, unstable angina, and a myocardial infarction. Hope you all understood about this section. Thank you.